Today, we're going to go in deep. I want to say something that is quite uncomfortable, but honestly, I am far more afraid. Well, I shouldn't say far more afraid. I'm more concerned of a small, deep wound than a large, shallow one. Why is that? I know with people are like, oh, it's a huge wound, it's big, but depth. We want to know how deep the wound is. Depth whispers. And in wound care, the whispers are the ones that usually kill. So today we're going to talk about sizing, the sizing of the wound. It is the one thing that matters the most. So in wound care, the most dangerous phrase, in my opinion, is saying like it doesn't look bad or saying it looks the same. No, we don't want that. Okay. Or saying, oh, it's stable. I'm like, what does that mean? Is it closing or not? So, I mean, I do like the word stable, but let's get back into it. So, because wounds don't heal by vibes, okay? They heal by centimeters or meters, whichever measurement system you're using. I use centimeters, depending on whatever device you're using. But measuring the wound every visit plays a huge role in wound care, and we're not going to gamble on the limb or the wound, okay? So today we're going to realize why size matters and why size is king in wound care because that's the best way we can metrically acknowledge that it's healing or is getting bigger, okay? So, I'm going to get in deep to it, okay? So, healing. We already know what is healing. Healing is organized tissue replacement and contraction. And epithelial migration. That's what healing is in wound care, okay? The only bedside variable that captures all of that is the change in wound dimensions over time. So what does size reflect in wound care? Size reflects the adequacy of offloading, the vascular sufficiency, the infection control, the mechanical stability, the cellular coordination. And if any of those systems fail, the size will expose it. The size of the wound will tell us that some part of these systems are wrong. So, what should we measure every time when it comes to a wound in wound care? A proper wound assessment includes length, width, depth, surface area, volume when applicable, undermining, tunneling, edge position, change over time, color, drainage, odor, all of that. That sounds like a lot, right? But we have to literally document all of that, especially in wound care for a proper assessment. So how do we measure a wound? So first we're gonna do length and width. They call it like the clock method, but I use a disposable ruler. I like to. I don't understand why we're gonna use a non-disposable ruler. Why would you do that? Some people, I guess, it's very sterile. I guess it gets sterilized every time it used, but I would use the disposable one. Okay. And on a side note, there are devices that literally take a picture of the wound and calculate the surface area and the whole sizing of the wound. That's those are pretty accurate. So, when it comes to measuring the length and width of a wound, use a disposable ruler, measure the longest length. So I know you want to cheat. I know people want to cheat with this, okay? Because no, I have rarely wounds are have a very symmetrical edges, right? And there may be a longer part, like let's say proximally, or there might be alongside proximal laterally or something like that. And you want to pick the shortest side so that it won't be so long, but pick the longest because that gives the more accurate. Because if that part is still open, it's open. Okay. So measure the longest length. Length is head to toe. What is length? Head to toe. What is width? Width is perpendicular to length. So we're going to do head to toe. So that's how we measure the length, head to toe. Okay? Width, opposite of length. So, 12 o'clock to 6 o'clock, right? Never measure diagonally unless it's the longest axis, okay? And, when it comes to Don't measure end to end without identifying the true longest points, okay? And changing your orientation between visits can actually affect the sizing and your measurement ability, okay? So keep that also in mind, okay? Next, the most underrated measurement is the depth. Like, we have to do better when it comes to that. Residency definitely had to do it. You had to document the depth. But I think a lot of people sometimes are afraid to even poke it. Poke it. They're afraid to poke it because I guess if they don't want to make it bleed and they get scared if they poke it or the granulation tissue is fragile. If it's fragile, that means there's something else is going on. If you can poke through the granulation tissue, something else is going on. Okay. So depth. This is the most underrated measurement. Use a sterile, like stainless steel. I use a curette, like I said. Find something stainless steel, okay, in my opinion. Do not use a cotton tip applicator because I feel like the wood or the cotton can get into the wound, okay? So insert gently until resistance is felt, okay? You've got to poke and feel if there's resistance. Now, I'm not saying poke and create a wound, okay? So don't put that word in my mouth. Nobody's saying that. But you're supposed to measure the deepest point to the skin surface, okay? Depth changes often precedes surface changes. So you have to remember that. And that's why wound care is so unpredictable because people don't understand what's brewing underneath. Wounds are very smart. Your body is very smart. People don't get that. Sometimes wounds love to mask themselves. They will heal over and they'll be like, I'm good. No, what and if you touch that area, I'm like, oh no, like literally there's still an open wound there. They want I wouldn't say they're the enemy, but they just want to cover it up even when they're not fully healed, okay? But a wound can shrink in area, but also deepen. And that's also a failure in the wound. So you have to measure the depth. You have to see if it's tunneling. We'll get into that. Undermining. Undermining is the tissue destruction under intact skin edges. So undermining is like okay, right? Like saying the edges of your robe, right? And you're able your robe yeah, your arms are in the robe and the robe arm is intact, but you're able to put your finger in it and turn around. So you could probe underneath the wound. It's going to be intact skin edges, okay? And like I said, we measure it using a clock face. So we'll be like undermining from 3 to 7 o'clock about like 2 or 1.5 centimeters, okay? But undermining usually indicates a mechanical or pressure failure until proven otherwise. Tunneling. Tunneling is a channel extending from the wound bed. Often, tunneling or showing signs will tell you that there's still an infection there. There's shear forces that's going on. There is deep tissue space involvement. And most likely, there is abscess formation. Okay. So, if the wound is tunneling, you got to investigate more, please. Surface area. So, surface area, how do we calculate surface area? This is like primary school. Length times width. Okay. Surface area usually gets overestimated in irregular shaped wounds, but mm, do your best. Lead times width, okay? Now, volume. Volume is pretty advanced when it comes to measuring for wounds. Volume is length times width times depth, right? So, particularly, it is important in deep diabetic foot ulcers, post surgical wounds, cavity wounds, and wounds with exposed tendon and bone. So that is also you could actually document the volume by length times width times depth, okay? So how often should you measure a wound? Ba- First of all, it should be baseline, the pre and post debridement. Okay, that was one of the biggest things, especially in clinical research. You had to have the pre, you had to have the post debridement. Okay, also weekly, at least weekly, because I know sometimes patients come maybe 3 times a week or weekly for 5 days weekdays, things like that. But if you can't do it all the time, at least do minimal weekly. And, if it's a high risk patient, it should be done every wound visit, and if the size does not improve by 2 to 4 weeks, you have to escalate the treatment options for the patient and figure out exactly what's going on, okay? Because I don't think anybody, well, anybody in wound care have really noticed the difference. It's like night and day when you finally remove the causations of why that wound is there. If it's like because there's an abscess or infected tissue, it's amazing once you remove that abscess and clean that up, how quickly the body heals over really quickly. It's amazing. So, when size defines the chronicity of the wound. So, functional chronic wound criteria, let's say how we define a chronic wound. First of all, it has to have less than 30% reduction in size in the 4 weeks of treatment, okay? Like, because remember, you're supposed to be seeing at least 50%, okay? So if the wound is not reducing by at least 30% in size within the 4 weeks of treatment, you're gonna have to change the treatment option of get and figure out what's going on. Static depth, that also is criteria for a chronic wound. Persistent undermining. Oh, I actually have to deal with this. Yeah, that's a problem. And then recurrent breakdown. Okay, time does not define a chronic wound, the wound behavior does. Okay, so let's do some special considerations when it comes to diabetic ulcers. So people will say, oh, look better than they are, or it hurts less than it should, it's progressing nicely. That's not I don't like that type of talk. It's not like the most reliable type of lingo to say, okay? So, what different devices should we use to measure the wound, a diabetic foot ulcer, or any wound, okay? Disposable paper rulers, okay? Those are cheap, accessible, board relevant, and operator dependent, okay? Kind of standard goal because it's disposable and it's easy and accessible. Wound tracing. There is something called wound tracing using acetate sheets. You could trace around the perimeter of the wound and then calculate digitally or manually. The only problem with that is infection control concerns and I've never really used that method. Next is digital planimetry apps. So things like a smartphone based wound measurement app, we used a lot of that, not an app, but it was a special camera that calculated the surface area of the wound, which I loved. So, way these apps work, you photograph the wound, the software calculates the area, and then tracks change over time. Like it tracks the change over time. Advantages of this, it improves the consistency because it's much easier. Documentation becomes easier, and you can trend the visualization. Okay, and the limitations are going to be lighting, angles, and collaboration, like calibrating it perfectly, okay? There are 3D optical wound measurement systems. So that's like it really is non-contact imaging. So these systems create a 3D wound model, calculate the area of depth and volume, reduce inter-observer variability, and it's used in advanced wound care centers, research, limb salvage programs, things like that. Okay, boards may reference it conceptually, but mm, and then ultrasound assisted assessment. That's a little adjunctive, but that's like when you want to assess the depth, identify abscesses, and differentiate soft tissue versus fluid. Okay. This is not really routine when it comes to measurement, but it might be critical if you can't understand or explain why the size is the size or it can't measure. So, what are some measurement mistakes that could actually cost a patient's limb? Okay. Not measuring the depth. That's why I said we always have to go in deep. You always have to remember, go deep, right? Go deep. Keep that in your head because you always have to remember the length, not the length, the depth. You always have to remember the depth. Keep that in mind because everybody keeps on just doing length and width. You gotta think about the depth. I don't care if it's even partial thickness, it still has a depth, little bit. Okay, partial thickness, a little bit. It still has some of that depth because it's not fully covered. Okay, so not measuring the depth, not measuring the undermining, not measuring consistently, relying on photos alone. And I'm going to say I am nobody perfect when it comes to this. Okay, ignoring the size as it increases because you're saying it looks cleaner. Like a clean enlarging wound is still failing. That's what I was trying to explain to one of my patients. Like, I hadn't seen this person for maybe over 6 weeks, and they were fine. And now the wound got worse, and I could see the tendon. I hadn't seen this patient in weeks, and the patient keeps on telling me that she's told by the clinicians that it's healthy and stable, and it looks good and it's clean and it's not infected. But I'm like, but why is the tendon showing now? So it progressively got worse. If it got to the tendon now, what's going on? So keep also patients keep that in mind, okay? Don't just take it looks clean and it's stable as an answer, especially if it's getting bigger, if you're starting to see parts of the body that you didn't see before, let's say you never got to see the tendon and now you do see the tendon. Yeah, I would question, why is it getting bigger? Why is it getting deeper? That's a problem, okay? If it's going down to tendon, that's a problem. So, clinical rules, hopefully you can memorize it. If it's not smaller, it's not healing. Area reduction predicts the outcome. Depth progression, I think, trumps the surface involvement. If the size increases, you have to escalate the treatment options, okay? And then pink does not override dimensions. So I hope that was super helpful. So let me do a quick, straightforward way to say the measurements of a diabetic ulcer. Let's just do quick, straightforward. So a plantar right forefoot ulcer measuring 2.4 centimeters in length, 1.8 centimeters in width, and zero point 0.4 centimeters in depth. So measure this with a disposable ruler and stainless steel sterile. I'm just going to say curette for me, okay? That's what I like to use. You can use pick up from one, two, you can use whatever as long as you put it next to the once you're done measuring the tap, use your finger. You can use your finger or you can mark it. Sometimes you have disposable black markers and you know, just mark that area of the depth and then you go to the ruler and then you see it. But the length, the width, and the depth are documented. It's in the correct units for whichever place you are at. And, it notes the abscess of any undermining. Didn't mention any undermining. Okay. So I wouldn't expect to see any undermining. And if there is undermining and we're not documenting, that's a problem. So next, a plantar left midfoot ulcer measuring 3.2 centimeters by 2.6 centimeters by zero point 0.6 centimeters. And it has undermining present from 3 o'clock to 7 o'clock. And it's extending 1.5 centimeters. Okay? The good thing about this, we are able to identify the undermining. It quantifies the undermining. We use the clock face orientation. We separate the depth versus undermining. Okay. Next, let me do a few high yield board questions. Okay. So, which wound perimeter best predicts healing? Is it A, color, B, odor, C, drainage, D, size reduction over time, E, pain level? It's going to be D, size. Size reduction over time is a wound parameter that helps best predict the healing. What is the minimum reduction in a wound area, like in the wound area, at 4 weeks that helps predict the success of the healing of the wound? Is it 10%, 20%, 30 to 50%, 60%, or 75? Honestly, baseline is I usually go by 50%. Okay. If the reduction hasn't been, some wounds do heal very slow, but they're still healing. But I go by 50%. If it's like 30, I can stop at 40%. If it reduces in size by 40%, I'm still working with it. I still think we're making progress. So next question. A wound decreases in its surface area, but it increases in its depth. And what did we say? Depth matters. Like if it's going deep, we have a problem, okay? So if the wound decreases in surface area but increases in depth, this represents A, healing, B, remodeling, C, measuring error, or D, worsening of wound dynamics. It's going to be D, worsening of the wound dynamics. Next, which technique ensures consistent wound measurement? Is it A, the diagonal measurement, B, photograph comparison, C, clock interface orientation with a ruler, D, patient report, or E, visual estimation? Going to be C, clock face orientation with a ruler. Next, diabetic foot ulcer shows granulation tissue, but forgive me, no size change after 4 weeks. Best classification system for this, or best way to classify this wound, this diabetic ulcer, is it A, acute healing, B, infected, C, adequately treated, D, chronic non-healing wound, or E, a hypertrophic scar. It's a diabetic ulcer that shows granulation tissue but no size change after 4 weeks. This one should be classified as a chronic non-healing wound. Okay. Next, which finding mandates escalation regardless of the wound appearance? I'm just going to tell you the answer: increasing the wound dimensions. If the wound dimensions are increasing, you have to figure out whatever you're doing is not working. Simple as that. I know I said that a little but whatever you're doing is not working. Which measurement is most productive? Ah, which is most predicative of limb-threatening progression? Which measurement? Okay, because we're all talking about size right now. Is it A, color? Is it B, drainage? Is it C, depth and exposure of deep structures? Is it D, odor? Is it E, pain? It's C, depth and exposed deep structures. Like I said, you know, okay, on a whole side note, I'm not gonna go into a rant, but I hate when people lie to the patients, okay? Yes, something is wrong, okay? If the wound is getting bigger and I never saw the tendon before and now I see the tendon, yeah, something is wrong, okay? When I hear patients tell me what other providers have told them previously, I'm like, and I'm just like, I s they expect the doctor to know everything. I get that, I get that, but I don't think people expect the doctors to lie to them. That's why they take everything so seriously that is said by the physician. Patients do not expect the doctors to lie to them, and unfortunately, they do get lied to because I had a patient telling me that the clinicians were like, "Oh, it's good, it's fine, it looks clean, it's not infected," but I'm like, "But why is the tendon showing now? Why before I saw it, it was looking good, full thickness, pretty much epithelialization along the border, but now the tendon is showing and it got bigger. What are they saying? Why are they saying that?" So honestly, patients out there, I need you to advocate for yourself. I need you to know the knowledge of this, okay? Because it's not normal for you to see the tendon in the wound, okay? So it happens. We all know it happens. But if the wound is progressing and you never saw the tendon and now you do see the tendon, yes, something is wrong. The wound is getting deeper, okay? So, long story short, please forgive me. So, no matter what, size matters, okay? When it comes to boards and things like that, I think they usually use centimeters. Always document depth. Note the change over time. Note the undermining tunneling, okay? Or state that there's none. That's another thing. State that there's none, okay? Another thing when it comes to depth, right? What does depth really tell us? It means that there's loss in the tissue layers. Remember, there are tissue layers, okay? We have to know this in wound care. I believe there's different layers of the tissue, okay? Because I don't want to go too into it. But okay, let me see if I can find the layers. Okay, first we have the epidermis, right? Then we're gonna have, well, they have like the basement membrane and all that stuff. We're not gonna go into that, okay? We're gonna go now to the dermis. The dermis, if the if it the depth is to the dermis, that means we're invading like an inflammatory zone and that will stall the wound. If the depth level is to the subcutaneous fat, that shows poor vascularity and we're in danger of necrosis, okay? If we see the fascia, remember infection bacteria love them some fascia. It follows the path of least resistance. They love the fascia. It is an infection highway. It helps the wound spread faster. So if you can see the fascia and it's open and it's already infected along that area, the infection is going to literally use that fascia as a highway, like Route 96 or something like that. Okay, even and forgive me if I don't even know the routes. Okay, next, if it goes to tendon, we have to always remember the tendon is a avascular tissue. Tendons are avascular. So what's going to happen to the tendon if it's out there exposed and the wound literally probes to tendon? It's going to desiccate. There's a risk of desiccation, which is drying out, and risk of rupture. Next, joint capsule. If it goes down to joint capsule, you are at risk of septic arthritis, okay? Was joint infection. So that is limb threatening. And then we all know if it goes to bone, that means it's osteomyelitis. We all know about the positive pro to bone test, and the patient is at higher risk for amputation. So depth is one of the strongest indicators or predictors of osteomyelitis. That's a clinical truth. So the deeper the wound, the higher the bacterial burden. The shorter the diffusion distance to the bone. The deeper the wound, the closer it gets to the bone. Okay, and the bone that's our core. That's us. Okay, that's our skeleton, and the higher likelihood of it spreading. Okay, so you can have like a point 0.3 wound and it'll be like 1.5 centimeters in depth. That's a problem, okay? And we already went through how to measure the wound, but quick, maybe two more questions. Which wound characteristic most strongly predicts osteomyelitis? Is it wound width, wound color, wound depth, wound proximity, drainage, or patient pain level? It's wound depth and proximity. So if it's not measured, it's not managed, and we have to remember that, and then size matters. If it's not documented, it never happened. That's one thing I learned, and that's why me, what is it, a medical scribe. I used to be a medical scribe too, so I know how it is, but it is nice to have a medical scribe. It really is. It helps a lot with documentation. So, shout out to all y'all medical scribes out there. Y'all have worked so hard. So, end the story. Depth matters, size matters, and like you said, if it's not documented, it pretty much didn't happen, and we can't do he say, she say. So this is Diabetic Foot Files, where we're literally just learning the most that we can about wounds and how to be better physicians and help our family relatives and anybody else when it comes to wounds, okay? But in the end, if somebody says next time it looks better, and I'm gonna be honest, I have been guilty of saying that, you should ask certain questions. As patients, you should ask, "How big is it today compared to last week?" That's a good question to ask, so you should write that down. How big is it today compared to last week? Because in wound care, size does matter. And this is Diabetic Foot Files with Dr. G. Take care of your feet because they take care of you.